Good evening, everyone. I'm Dr. Shrikant Ban, Medical Team USC. I would like to welcome you all for today's CME India. Today, we are going to focus mainly on pharmacotherapy of epilepsy. And without further delay, let me introduce our today's delegates. Technical team, can you please share the screen for introduction? Thank you. Thank you. It's my pleasure to welcome our Dr. N.K. Singh, sir. Sir is a diabetologist, director at Diabetes and Heart Research Center, Dhanbad. Sir had multiple responsibilities like chairman as well as executive member for RSSDI previously. Previously, sir also had different responsibilities as ex-governing body member for National API and other responsibilities also. Along with that, sir is also actively participating in different publication at national as well as international journals and actively participating in different CMEs and conferences also in the form of chairperson or as a speaker also. With this, I would like to hand over the session to Dr. N.K. Singh sir to set the context and introduce our other members. Over to you, sir.
Yeah, thank you, Dr. Srikant. So today we have got a very exciting session on the pharmacotherapy of epilepsy and update. Adherence is the key. So can we have the next slide? So next slide. Yeah, so I have great privilege and I'm happy to just introduce the audience. Uh, Dr. L. Padma, who is the professor and HOD Department of Pharma and at the Saptagiri Institute of Medical Sciences and Research Center and also professor and HOD at Bangalore. She is executive committee member and scientific writer of the Family Physician Association. She is known for conducting various CMEs and workshops, so many paper presentation at multiple conferences, especially articles written on the anticoagulants in pregnancy, drugs used in pregnancy, and regular guest lectures for BSOG Society and guest lecture for patient awareness programs at factory levels and community levels. So today we will have an exciting session. We have got a few, two moderators today. Can you get to next? Yeah, next. Yeah, so Dr. Umesh Khan will be one moderator today. He is a senior consultant physician, Jamshedpur, and FICP, also the FICCMD, and is Fellowship of Diabetes India. Now he is the vice elect president at the RSSDI Jharkhand state, and he has also been the past chairman of CCDSI Bihar and Jharkhand, past chairman of API Jharkhand, past president of IMA Jamshedpur. He is a very eminent physician at Jamshedpur. Next. Next. Yeah, so I also welcome Dr. Prerna Kapoor. She is senior physician at Sanjay Gandhi Institute, Postgraduate Institute of Medical Sciences, Lucknow, nodal officer for General Hospital, SGPGIMS. She is having the member SGPGIMS Medical Board, a reviewer of the JAPI, reviewer of the Journal of Gerontology and Genetic Medicine, fellowship of the Indian Society of Hypertension. She has got so many awards also. So welcome Dr. Prerna Kapoor. Next we have got our from CME India team, Dr. Akash Singh. He is the senior consultant medicine, diabetology, non-interventional cardiologist at Barodara, Gujarat. And he is well known for his academic career with so many publications and invited faculty all over India. Welcome Dr. Akash. Next. And Dr. Vijay Patni, also known to us that he is the current designation nurse of the HOD Diabetes Wellness Clinic, Kolkata. So many memberships, so many. He has also just edited a very important book on the pre-diabetes and lots of awards and achievements. So welcome, Dr. Vijay Patni. With that, now well, Dr. Umesh Khan has joined and Dr. Prerna Kapoor is here. So Dr. Umesh Khan, can you now cordially invite Dr. L. Padma to start the CME? Yeah, Dr.
Yes,
Umesh
yes.
Khan,
Yeah,
can you
thank you.
start?
Thank you, Dr. N.K. Singh, for detailed introduction of all of us. Let us start with the subject. The speaker is none than Dr. P. Padma. She's a very eminent physician, and she's going to discuss on pharmacotherapy of epilepsy in update, and adherence is the key. So without wasting time, I request Dr. Padma, please present his paper, her paper. Thank you.
Yeah, welcome, madam.
Thank you, sir. Thank you for your introduction. Thank you. Forums also, students or physicians can have these amenities and see that they look after their
Madam,
patients
your
properly,
voice is not
because
coming up.
everything
You
is becoming very. Sir,
please share the slides. Yeah.
1 minute, sir. Yeah. 1 minute, one.
Okay.
Now it's okay, sir.
No, it is
Can you
not
hear
coming
me?
up. Yeah,
Hello?
we can hear you, but
Hello.
there is sharing is
Audio
not
audio
here.
is not.
Audio is now okay, but to just go for the
Sir,
sharing option.
I have put the maximum, sir.
No, but sharing is not possible.
Sharing
There,
option.
Yeah.
tech team, can you see?
1 minute, sir. Can you see, sir?
No, I think
Hello?
you have to.
Not
Hello?
clearly.
No,
Sir, I
can
have
you
shared it.
rejoin, madam? Can you rejoin and then share? We're not getting it.
Okay.
Technical team, please support.
Yeah,
Yes.
Uday, can you see what is happening?
Doctor facing low internet connectivity.
So there is problem. She just joined now. Madam, have you joined? I think she's trying to join. I think still we are not able to see her. Uh,
Connectivity is very poor.
yeah, I think there is some problem with internet from our side. So we'll wait and I will calling. I think this topic was really very interesting that uh, recent, yeah, so
सर
madam
तब
is
तक
here.
हम लोग थोड़ा बात करें
Yeah, madam, can you give
क्योंकि
some
we
your,
cannot keep the audience waiting. हम
yeah, so
the
can we
main
have
thing about
some,
First of all, thank you all. Thank you, CME platform. Thank you, Dr. NK Singh, that we are having this discussion today. Actually, it's a very important discussion. As we know, epilepsy is such an important disease in the prevailing era. The reasons are multifold. We all know that. A problem ye hai कि every time a person gets a breakthrough seizure, it's a problem for that person. So one of the biggest important things in the therapeutics of epilepsy is maintaining the level of the medicines and therefore sticking to them. And iske liye, because obviously if the patient is not going to have that, that means that they may have a breakthrough seizure. That means that they may be driving, they may be somewhere, they may get injured, their family members get upset because this is happening. Somebody who's newly married, this may make them very underconfident, somebody in a new job. So it's very well understood that we have to keep the person seizure free. Also, every seizure activity is going to create some problems in that patient's brain, the structure and physiology. So we need to keep the person seizure free. Now, so for this, a regular dose of anti-epileptics is very, very important. For that, every person who's taking anti-epileptic, we have to be very well aware of. As doctors, as physicians, it is our responsibility to explain to them that they have not to miss the dose, come what may. And I will invite now couple of comments from Dr. Umesh and other participants also, so that we can take it forward before we listen to madam's lecture, because madam is a pharmacologist. She will tell us more of the pharmacology of it. So let's discuss the medicine and the preventive aspects of it till then.
exactly, Dr. Prerna Kapoor, I think you have given a starting good input that epilepsy is such a important problem that even in our diabetology practice every day, we get some sort of problem like this. So many times also we are getting that seizures are coming up after very high sugar. So that is also happening and lots of abnormal movements. So that sometimes become very difficult to just differentiate. So Dr. Umesh Khan, in your practice, how many cases you are seeing of the such epileptic seizures and how do you approach for that?
See, as far as epilepsy is concerned, now there are certain changes we have seen. First of all, the name of the drug, this treatment has been changed. Now it is known as anti.
We are not able to hear you. Are you?
Hello, sir.
Yeah, Dr. Padma, have joined. You have joined.
Hello, sir. Now,
Yeah. So you share the slides. Yeah. Now it is okay. Coming up. Yeah. So I think it is. Yeah. That's now you go for the slideshow mode. Just go for slideshow mode. It is coming up.
I shared the slide, sir.
You
That's
have
okay,
shared the
sir.
slides. Just go for the slides so full mode.
Ma'am,
Yeah,
from the
that's
right
fine. That
bottom,
yeah
go into the
yeah
slideshow mode.
yeah.
Then only slides will move.
Double click there. Yeah, that's fine. That double click. That time it already came.
Full,
So
full show only. Yes, sir.
I think it has come up, but yeah, now it's fine. But now you can go.
Yes.
Okay, sir. I
Yeah,
can
Yes.
start. Yeah.
Yes.
yeah, you start.
Yeah. Uh, Good evening, all of you. Thank you, sir, for giving me this opportunity when I asked you for a session, because I thought disseminating the knowledge is better. And today's children should be given all these opportunities. at least to make give an opportunity to practice with these modalities. With this, I'll just talk about anti-epileptic drugs. A clinician guide should be there because adherence is the key here. Not just the proper cure or prophylaxis cannot be given here as such. So we have to start treating, but adherence is the key both for the practitioner as well as for the patient. So once we give this sort of adherence and counseling, I think most of the epilepsy or the seizures which are upcoming and maybe even lifelong, because 30% of the people do suffer from drug resistant epilepsy. So in such cases, we should have good amount of counseling not only to the patient but also to the attenders, which where they can lead a good normal life and a good quality of life also. So with this, I'll be dealing with mechanisms, pharmacokinetics, drug selection, adverse effects, and anti-epileptics in special situations, as well as resistance is a common entity in all diseases nowadays. So we will just take up in the last what are the emerging resistance strategies, what we can do, and hence see to it that the patient leads a good quality of life. And last but not the least, I would like to say three of my personal consultations, what I have done with these sorts of seizures in different age groups where it has been quite normal, and all three are in a very good position, leading a good normal life, and they are all settled abroad also. So I would like to tell you in the last what we have done in the last 25 years from phenobarbital to today's latest drugs. So coming to definition, because all seizures need not be treated also. So we have to know the difference between seizure and epilepsy. Seizure is nothing but a transient occurring of these signs and symptoms which are excessive, abnormal, asynchronous, and it is a neuronal activity in the brain where it can imitate a pathological event and need not be a disease at all. Whereas in case of epilepsy, we do have and unprovoked seizures which can last long, two seizures 24 hours apart, and one unprovoked seizures where more than 60% of the recurrence risk over 10 years is present, and there is a diagnosis of epilepsy syndrome. But nowadays we are seeing this drug resistant epilepsy as a third variety, where there is a failure of achieving sustained seizure freedom after a trial of two or more drugs which are well established and well tolerated. And these patients will warrant the consideration of surgery or neuromodulation as the case may be. So the classification, the onset determines the treatment selection here. Based on that, we have a focal onset seizures, a generalized onset, and an unknown onset which has come out recently. Because in our days, we used to read only about the focal onset and the generalized seizures, and later on we used to see most of the time status epilepticus, where we have treated them even on the roads also. So such was the frequency. But now, as the patient are aware to a great extent, we are not seeing to a very great extent on the roads or off things. And so we have come across like focal onset, generalized onset, as well as unknown onset seizures. And here, most often, we have the older drugs added to that, lamotrigine and levetiracetam in focal onset, whereas in generalized, we prefer valproate as the first line and later on the newer drugs, whereas in the unknown onsets, all broad spectrum agents are seen. Whereas in older times, we had only valproate. Now we have several of the drugs which have got a broad spectrum action, so that adding a combination therapy might give a greater effect as well as compliance. So when do we initiate these therapies, or when do we observe, or when do we treat? Because some of them do not require immediate treatment. Whenever we want a treatment, we have to see that there are two unprovoked seizures, more than that, and one seizure and one epileptoform, EEG, plus the structural lesion. And it should be identified as an epilepsy syndrome. And if not, A single seizure after a tumor infection or clear epileptogenic lesion can be there, or the last but not the least, if it is a status epilepticus, immediate treatment is the choice. We have to act than to think. But we can observe or defer or still think and find out the cause whenever there is only a single provoked seizure, like metabolic, like hypoglycemic seizures, or drug related, or febrile seizures in a child, or in a single unprovoked seizure with low recurrences, or febrile seizures in children most of the cases, and seizures following acute head injury without any extra features. So the clinical decision should weigh the seizure risk, the consequences to the patient, whether he is, what is his occupation, especially driving, and also the safety. Later on, we have to think parallelly about the drug toxicity profile also whenever we initiate such treatments. Now, the goals are mainly seizure control with drugs. Apart from this, the drug treatment might not be sufficient because many of them will control seizures and not epilepsy. But at the same time, parallelly, we do have adverse effects where we have to minimize and choose the drug, and also have some sort of psychosocial functioning. And also we have to look after the 360 degrees of his physiological life, and hence come to an end with a good quality of life so that he can lead a normal life till whatever God has given to him or her. So just a little bit about the historical milestone in AAD development, from serendipity to mechanism-based discovery of late. We had only bromide as well as phenobarbital till about 1912 to 1990, so to say. Then came the other newer drugs, other older drugs like phenytoin, ethosuximide, carbamazepine, and valproate. And later on, after 2000, we have several of these newer drugs which can be even broad spectrum and also have a very less adverse effects, and hence the patient can lead a good quality of life. We can assure to a maximum extent a good quality of life rather than the older drugs which had many of the adverse effects as well as contraindications also. So before seeing the actual drug review, we shall go to the mechanisms of action. These are the basis. Apart from these, we have to weigh over the adverse effects and then think of the drug with all the 360 degrees, keeping in mind like age, sex, their occupation, etc., etc. Then we can decide which drug to administer in each of those patients, because every individual is different at any given situations, and two individuals are obviously different wherever and whatever they are. So the mechanism of action are mainly two things. They either reduce the excitation or enhance the inhibition. The excessive excitation are mainly through the sodium channels where which are activated, or the calcium channels, mainly the T-type calcium channels, or the glutamate, which is the excitatory neurotransmitter, or of late we have seen with synaptic vesicle 2A protein, where there is vesicle recycling, and the target is almost the newer drugs where we are using day in and day out. Apart from epilepsy, we are also using it in non-epileptic conditions also. The ones which reduce the inhibitions are GABA A receptors, GABA synthesis with catabolism, or the reuptake, or we will see to it that it opens up the potassium channels, thereby there is membrane stabilization as well as there is the inner current of potassium channels to see that hyperpolarization exists uh, rather than the increased abnormal excitation. So coming to each one of them, a glimpse on each one of them. We have the main ones are voltage gated sodium channel blockers, the most widely used mechanism class. The main action is mainly the inactivated channels are targeted. there is prolonged recovery time in the inactivated sodium channels, and this should be use dependent or frequency dependent blocked, and this is the basis for selectivity against the rapid firing ictal neurons with limited effect on the normal neurons. So there is selectivity. Similar thing, we can have a corollary with the local anesthetic also. They are also in a similar way we use for these use dependent and frequency dependent blockade. Amongst the lot, what do we have now? The main action with these are with the drugs with phenytoin, carbamazepine, lamotrigine, lacosamide, as well as oxcarbazepine. But phenytoin and carbamazepine mainly have voltage gated sodium channel blocking activity, especially the inactivated channels, and hence they prolong the recovery of these inactivated, so that resting time is also prolonged, and hence the frequency of these firing of these neurons is suppressed, and hence acts as an anti-seizure activity. This phenytoin has got fast inactivation, but we have to look after about its pharmacokinetic features mainly, though it is active only against GTCS, focal as well as status. Phenytoin as such is not active against status. Phosphenytoin can be given IV, and this is given nowadays for status epilepticus. So we have to weigh out the pharmacokinetic features as well as the adverse effects, both at the therapeutic level as well as at the excessive level, where we have a different sorts of adverse effects, and hence we have to be careful. And sometimes, though we supplement for some of these adverse effects, still we do not find any remedy, because we are not completely treating the pathways, and hence we cannot get complete cure even for the adverse effects also. In contrast, carbamazepine also has the same problem with pharmacokinetics, but it is mainly with the auto-induction, unlike phenytoin, where we have the other pharmacokinetic features, which I'll come later. But along with that, parallelly, the person also experiences hyponatremia. If at all, if they are elderly, hyponatremia itself might be a cause for we are treating one disease and introducing one more disease. This is a problem, and so we have to be careful. The newer drugs, though they have got both fast inactivation as well as slow inactivation, the problem is only with of late we are seeing with all the drugs which come with clinical trial, they have to undergo both cardiac as well as renal, and here the same problems also exist here, especially with lacosamide, where we have to think about the renal functions, and hence in any case of dysfunction we have to keep an eye whether we have to really look into this matter or not. And along with that, parallelly, we have PR prolongation earlier to QT prolongation. This carbamazepine is used very commonly, which is a prodrug, and we would love to have prodrug because of the absorption and fewer drug interactions. So we would always like to wish that every drug is a prodrug, so that it is active to the maximum benefit, and hence here also we see the same problem like carbamazepine, where the patient can experience a lot of hyponatremia. So the other big target is the GABA enhancement and the glutamate inhibition. The main ones of late of the ones what we know, and we do know that there is large margin of safety, is benzodiazepines. Phenobarbital nowadays we do not use. We do use it in some of these government hospitals as well as in NIMHANS because of its low cost, but we do have some 4-5 problems, major problems with phenobarbital. So we have to keep on monitoring. I will tell you two instances regarding phenobarbital, what I experienced in my practicing life. So we normally use this benzodiazepines. Of the lot, the clobazam and clonazepam are the ones which are very commonly used nowadays. Diazepam and lorazepam amongst that. The lorazepam is the one which is used very commonly in status epilepticus as well as an add-on therapy. They are all GABA facilitatory in action. they will they will only facilitate, increase the frequency of opening up of the chloride channels, and so they have got a good margin of safety compared to phenobarbital. They can never become mimetic, and they do not have any retrograde or anterograde amnesia, and hence do not fall under drug automatism, and there is no enzyme induction or auto induction, and so we can be very safe with benzodiazepines. Also, we do have an antagonist, flumazenil. So these are the benefits of benzodiazepines, and most of the times we would like to add as an add-on drug, because the problem is mainly we have the tolerance with these drugs. Valproate, apart from its GABA enhancement and glutamate inhibition, it is also a sodium and a calcium channel blocker, the most wanted anti-epileptic, which is a broad spectrum anti-epileptic drug. It is used in all types of epilepsies, and nowadays we do have a non-epileptic uses of these also, where dry valproax is used in migraine, and this valproate is also used in bipolar disorder as well as in trigeminal neuralgia. So, whereas tigerbalm and vigabatrin, though they have got good mechanism of action, we are very much worried about its adverse effects, and hence there is a box warning for this, and this is kept as the last drug of choice, especially in tuberculosis as well as drug-resistant epilepsy. In case of glutamate inhibition and synaptic vesicle 2A binding, we have got the latest drugs like parampanel, levetiracetam, and brivaracetam. Amongst the lot, we are using levetiracetam, which does have the synaptic vesicle 2A protein binding, which inhibits the exocytosis as well as it modulates the neurotransmitter release, and this also comes under the category of broad spectrum drugs. So whenever we cannot use valproate because of its adverse effects, enzyme inhibition, and it is contraindicated in the reproductive age of the females, then the drug of choice nowadays is most often levetiracetam. Apart from that, it is most commonly used in PTSD also. The analog or the alternative to levetiracetam is brivaracetam, where it is still broad spectrum and it has got a higher affinity, 10 times higher the affinity to SV2A, and hence this has got a longer duration of action. The blocking activity is much more complete than levetiracetam, and so most of these neurologists are preferring brivaracetam to levetiracetam. So, based on all these, we found out the drugs, but at the same time, when the patient comes, we definitely diagnose the seizure or the syndrome, and it should be evidence-based to have a first choice of the drug. So, in all the focal onset seizures, the older drugs are carbamazepine, which is commonly used, which is quite safe compared to phenytoin or valproate or ethosuximide. So, most common we use carbamazepine and carbamazepine has got an auto induction, so we have to keep on calling the patient for revisiting and refilling, and because of auto induction we have to keep on increasing the dose, where there can be a chance of Steven Johnson syndrome in these cases also. Because of that, most of us have switched on to lamotrigine and levetiracetam. The only problem with lamotrigine most often is the skin rash, which can go on till Steven Johnson syndrome. So levetiracetam is the drug of choice and the preferred ones nowadays with all the neurophysicians. Coming to the generalized one, where we call it through history, or we cannot find with EEG findings, etc., etc. In such cases, we do resort to valproate first. But we can do this in all age groups except in reproductive age groups, where we should not use this because of its teratogenic effects. Some of the adverse effects we do have it in normal persons also, whether males, females, or children. But the problem is, because of these adverse effects, we hinder using valproate and switch on to lamotrigine or levetiracetam, where there is a specific binding of SVA2, which we were not seeing with the older agents. In case of absence seizures, we do not use ethosuximide nowadays. The drug of choice is mainly valproate, because ethosuximide was long back withdrawn, But sometimes with experience, we cannot go only by protocols. So in case the person has got experience with ethosuximide, still some of them are still using it. I have come across some of them when they come for refilling the prescriptions. The juvenile myoclonal epilepsy is the one where we are using number of drugs, but the one which is very highly effective is valproate. In status epilepticus, the drug of choice is mainly fosphenytoin or lorazepam, as many of us know, and even at the MBBS level, we do treat with this. We have to act for emergencies, not think for as we think for chronic diseases. And in children, most often we have rectal suppositories where we use diazepam as the most common drug of choice, where we get the remedy within about 10 minutes, and we can introduce one more if at all it is need as on need basis. Pharmacologically, how do we distinguish these drugs? We distinguish it as based on the spectrum, the safety, and also the uncertain seizure types. Based on that, we classify it as broad spectrum and narrow spectrum. We do not use the chemical classification nowadays. We have resorted to inform people those things. So we have to think whether we should use a drug with multiple mechanism of actions, or is it sufficient with a single drug mechanism of action with less adverse effects, and so we can reduce the central nervous system side effects or the untoward effects so that they can be as normal as they can before the onset of these seizures. Thinking in that wise, the effective across focal and generalized seizures are valproate and the other 8 drugs of the newer category. And in the narrow spectrum, we have got mainly carbamazepine and phenytoin, the others being new, the last choice being tigabayne, as well as eslicarbazine, as well as ethosuximide, which, and these drugs should may worsen absent seizures if used in generalized epilepsy. So we have to be careful, and you should see whenever we use broad spectrum, we should prefer when the seizure type is uncertain or mixed, or we do not find any EEG abnormalities. In such cases, to be on the safer side, we start using broad spectrum drugs. Coming to the individual drugs, what important things what we have to look upon when we are in the front of patients. So we will start with phenytoin, which is the clinical enigma, where we see which is very efficacious but pharmacokinetically unforgiving. What are those points? The main points are it undergoes mixed order kinetics. So once it undergoes mixed order kinetics, the concentration increases. Once the concentration increases, the side effects at the higher therapeutic level will become very obvious in day-to-day life also. Second, it is an enzyme inducer. Third, when it is an enzyme inducer, today is the day of polypharmacy. So in such cases, what happens, this being an enzyme inducer will reduce the therapeutic profile of the adjacent drug, and hence the patient can come back with another disease, or because of the adverse effects, they can come back with another disease. And so we have to be very careful. Drug history is very important now. We should keep an eye on drug history before the present and the past history nowadays. So this is the main problem with zero order kinetics as well as enzyme induction. The third one is it undergoes hydroxylation. So a pharmacogenetic problem also might exist here. So you have to think twice, though it is the most favorite drug in grand mal epilepsy. And next, the side effects at the therapeutic level as well as at the higher level, both are seen here. So we have to keep on having therapeutic drug monitoring, which can be quite costly also. So in such cases, when the patient cannot do it, we have to start low, go slow, and keep on adjusting the dose to see that the patient do not land up in such sorts of adverse effects. One important point about this phenytoin is it increases vitamin K metabolism. Because of this, the concentration of vitamin K dependent proteins is decreased in the body, and hence also has an effect on calcium metabolism. So what do we do whenever we add phenytoin? We straight away write some calcium tablets, but we do not see the effect as much as wanted. Why is it so? This vitamin K is needed for this calcium absorption into the bone. So when this vitamin K is not there, this osteomalacia is not ameliorated as we have not administered vitamin K. So in any case where we administer phenytoin, both vitamin K and vitamin D has to be administered to get the necessary effect of the adverse effect which we can forego very easily. So the adverse effects for our convenience, I have divided into dose related, cosmetic, metabolic, idiosyncratic, as well as cardiovascular. Amongst them, I think cosmetic is the one which bothers everybody. So gingival hyperplasia is taken care by good hygiene. Hirsutism, nowadays too much of cosmetologist is there, so you can think, but when we start low, go slow, most of these can be managed to a very great extent. Metabolic, as I told you, that folate deficiency might occur. There can be anemia, and also there can be neural tubal risk, very less compared to sodium valproate. But definitely we have this Hydantoin syndrome where cleft palate is most often seen. And in idiosyncratics, we see mainly blood dyscrasias in many cases of phenytoin therapy. And we have to be careful whenever we have rapid IV infusion, because both of us are diluted, doctors are also diluted, nurses are also diluted. So they just want to finish the work. So they go with rapid IV infusion where they can really have very severe cardiovascular adverse effects. But in as a corollary, or we still use phenytoin in case of digitalis induced ventricular arrhythmias as a second drug of choice, because lignocaine any day is safer compared to phenytoin. Next, coming to valproate, where we use it very commonly, which is the most effective single drugs when we don't know the cause. But we have to bear in mind that it is a significant teratogen. So 18 to 42 years is absolutely contraindicated in females, in reproductive females. So here, this blocks all of them. All of us know sodium, calcium, increased GABA, decreased glutamate. In addition, it also has got histone deacetylase inhibition, which contributes a major effect for the suppression of the seizures. So it is used in all types of seizures, but we have to bear in mind three important things in case of valproate. One is alopecia, which may be transient. Second, hepatotoxicity, where SGOT and SGPT can increase. Third, it is an enzyme inhibitor. It is an enzyme inhibitor. So we have to be careful when we add the drugs, because as I told you, polypharmacy is the choice of today's prescriptions. So we do not bother about the other diseases, nor the patient bothers to tell us. So these are the problems which are met. So we can see that the toxicity increases with enzyme inhibitors. So we have to be careful. These three should be kept in mind whenever we think of valproate, where we write it left and right in any case when we don't know the cause, or where we are highly bothered. In such cases, we do have these problems, and so we have to bear in mind before starting the prescribing valproate. But we have, whenever valproate is prescribed, we have to give high dose folate, that is 5 milligrams per day, to prevent the folate deficiency. And by chance, suppose the lady or the girl comes at about 16 years, and we do not think as a reproductive age, but they come at the lower class people, so they get married early and they become pregnant early. In such cases, there might be problems. So for these, to prevent as prophylaxis, we are supposed to add high dose folate whenever we add valproate or think of valproate as the first drug of choice. The key drugs at a glance, They are carbamazepine, lamotrigine, as well as levetiracetam, where we are using very commonly nowadays. The only thing to remember about carbamazepine is auto induction, so you have to increase the dose. These enzymes themselves will increase the metabolism of carbamazepine, and they are potent CYP3A4 inducers. So it is a problem both for itself as well as for others. So we have to be careful. The first point, we have to be careful about this. And the four most important adverse drug reactions, we have to give them some sort of counseling. We should not tell them as we are giving an AK-47, but we have to tell them that they can suffer from diplopia, ataxia, especially hyponatremia, and rashes, or something like a toxic epidermal necrolysis, or even Steven-Johnson syndrome, which can be even genetic, especially in Asian patients. So these are the ones, and they have to be careful with macrolide antibiotics, especially erythromycin, where we are not using to a great extent nowadays, but still dermatologists happen to use erythromycin both in the topical as well as systemic forms. And so these are also enzyme inhibitors. So two enzyme, and this is an enzyme inducer. So both of them put together can worsen the seizures also, because the carbamazepine concentration can increase, though it is an enzyme inducer. But the same thing, in contrary, we do not see all these with lamotrigine or levetiracetam. So these have become the drugs of choice nowadays, though we have some of these smaller key areas in children, especially behavioral problems, or like in lamotrigine, some sort of rash-like risk. So these can be taken and counseled properly, and hence the patient can still be on drugs and attain to normal lifestyles, and hence can be one of the biggest persons even in the armamentarium, so that they can lead a normal life. So in the key drugs, we prefer to have in the reverse order levetiracetam, lamotrigine, and later on carbamazepine. But thinking of the cost, carbamazepine would be the greatest choice for most of the people in India. Coming to the third generation, apart from ethosuximide, we have lacosamide, parampanel, brivaracetam, as well as canamidol. Amongst these, the first two are not used to a very great extent because they have to undergo cardiac screening, PR prolongation, drug interactions, and especially with parampanel, there's a box warning also because of psychiatric areas. And so we have to be doubly careful, and these are not used to a very great extent. But apart from these two, we have started using brivaracetam, which have got a very uh, good mechanism of action. Apart from the older ones, it binds 10 times higher to the SV2A binding, apart from its sodium channel blocker or even the other actions, and it has got a rapid CNS penetration and very few adverse effects, especially psychiatrics, and it is quite well tolerated, but the clinical experience are less with the common ones, so we fear little. Apart from that, we do have a very great, nice key features of pivatristram. The latest one, which have got a multiple targets, is cannabidiol. So it acts on TRPV1, CB1 independently, and all the anti-seizure mechanisms what we saw with the other drugs, and some of these are still incompletely understood. But FDA is approved for Dravet syndrome as well as LG syndrome, and the significant interaction with clobazam should be kept mandatory. And so we should not administer them together along with that hepatotoxicity. And so for hepatotoxicity, it should not be combined with valproate, but monitoring is the key. So of all the things, whenever we are sitting in front of the patients, what should we know exactly? In all these anti-epileptic drugs, we have to know about the pharmacokinetics. So the clinician should think, the moment they think about anti-epileptic drugs, they should think of pharmacokinetics, there is no bar for this at all. There's no excuse for this at all. Especially, I'll give you one example for each one of them. Absorption, especially phenytoin. So if at all they change the brand, but of course, today is the day of generic drugs, okay? But still, with phenytoin, they have to take the same brand because the bioequivalence may differ and hence the bioavailability may differ. The physician would have called them for 3 months for revisit, but the patient comes back within 2 months. So the stress should be done and it should be recorded in the prescription that same brand should be taken, or they should take the number of tablets for 3 months completely, so that in the middle they should not have a problem in the pharmacy shop that they are not getting the same brand. So this is the main problem with, especially with phenytoin, and so we have to be careful with these things, and we have to record that they should be taken with food or without food, or fat can increase its absorption. So these are the points which has to be taken with absorption. With the distribution, we have to be careful when the person is on the treatment with warfarin, okay, or any of these drugs which have got great plasma protein binding capacity. Okay, even then we need not bother to the great extent special, and we have to bother mainly for warfarin, because we have to the internal bleeding can be anywhere and everywhere. In some of the parts we cannot even recognize. I had a patient where not with these, he has normally also, but that internal bleeding could not be made out unless and until he underwent laparotomy. So such is the problem with warfarin. So we have to be more careful with warfarin than with other plasma protein drugs. This is because only the free fraction of the drug is pharmacologically active, and with each circulation, the free drug undergoes metabolism. So the amount of the interaction which takes place compared to absorption and metabolism is very less in distribution. So we need not as much as to say bother at the distribution level as much as we bother about absorption as well as metabolism levels. So in metabolism, of course, we have to keep on bothering because of autoinduction, and also there is a broad spectrum enzyme inducers. We knew only enzyme inducers. Now we know some of the broad spectrum enzyme inducers. That means they do not induce only CYP enzymes of majority of the varieties, but also they will induce UGT also. So when it is a broad spectrum enzyme inducer, the therapeutic failure will be of a great concern. So, and especially if it is an autoinduction, the problem cannot be solved and they can go on even to drug resistance. And the patient also will not come back at proper time, which was the case about 2 decades ago. So now they do not come back, and so they can land up in certain of the resistant cases where we are unable to treat at any cost. The second most important thing is renal route. Nowadays, every person will be suffering most often from CKD, though they manage even at creatinine 4, they manage medically, but still the stress is there on the patient, and so we have to be careful in case of renal dysfunction. As I have told you, autoinduction is the main concern which can really be a bothersome regarding the disease for the patient, and for us the combination therapy which has to be treated. And lastly, we have to bother in females the pharmacokinetics in pregnancy, where there is increased volume of distribution, decreased albumin, increased induction, lower plasma levels, and hence monitor the levels each trimester as well as postpartum. But we have to measure only the free drug levels, not the protein bound levels, because once they are plasma protein bound, they are in the storage form, they are not active at all. After knowing the PK problems, now we will come mainly to this drug-drug interactions at the metabolism level. Why I have stressed and put it in a complete one slide is because they are all very critical, because today is the day of polypharmacy. Because of this, we have to remember day in and day out, the moment we start writing in the pen, we have to think of drugs of these inducers and inhibitors before we write any of these drugs. So those enzyme inducers which increase the clearance of the administered drugs, so experiencing therapeutic failure, especially with contraceptives, warfarin, calcineurin inhibitors, antiretrovirals, and some of these anti-epileptic drugs like lamotrigine. So in these cases, especially in contraception, we should not use oral contraceptives, but we can use barrier contraception. In case of enzyme inhibitors, the levels can go high. The levels can go very high. Toxic levels can be attained. And so we have to be careful whenever we use these enzyme inhibitors. But that is not the case, especially with lamotrigine, which is also an UGT substrate, but it is neither an inducer nor an inhibitor. So we can think at least one or two drugs to be quite safe and list it as first or second drug of choice compared to others which has got many enzyme inducers and inhibitors actions with their drug interaction level to the maximum extent. With these problems, we have to land up in therapeutic drug monitoring. But how many caners can afford for therapeutic drug monitoring, though we keep it in mind with all these drugs? In certain of these cases where we want therapeutic drug monitoring, clinically also can be done. I hope most of you know this. Just to recollect, therapeutic drug monitoring can be done by giving a clinical holiday, drug holiday, which is very commonly done with digoxin, which is the last drug of choice in congestive cardiac failure when all these newer drugs have also failed. But I don't think that is the choice today, but still at times where there is a concern of using digoxin, we do not do therapeutic drug monitoring. Rather, we give a holiday. We always say to the patient, Sunday is a holiday, so take digoxin holiday on a Sunday so that the plasma levels are monitored at the clinical response level. But in some of the cases, we cannot do it. We have to resort for therapeutic drug monitoring only for guiding. Only for guiding, it will not replace the clinical assessment. And so these are the drugs where we want to have this sort of therapeutic range, and that should be a guide to the clinical assessment, and it should never be a target. And hence, we have to treat the patient and not the therapeutic drug monitoring levels routinely. And a patient seizure free at a subtherapeutic level does not need a higher dose at all. And the levels are most useful only for these conditions to confirm the compliance, to see that the drug is taken properly and the person listens to the doctor very sincerely and dedicatedly. And whenever we are suspecting toxicities, to decrease the dose, or when we have a polypharmacy, to know about the interactions. And also we should see if the person is at a high risk, like in pregnancy, illness, cardiovascular conditions, etc. So, and it should be a steady state trough level where we have to take out the blood and look for this numbers, and hence interpret the therapeutic drug monitoring. With these, what adverse effects are we expecting and what should not happen to see that the patient will have good compliance? And there should be nothing like non-compliance whenever he starts for revisiting or refilling the prescriptions. So, though black box warning are seen in variety of conditions, especially for the suicides, in such cases, we have to counsel the patients. So the adverse effects are divided into dose-related adverse effects, idiosyncratic adverse effects, and chronic adverse effects. So in each one of them, we can consider whether they are predictable or unpredictable or bizarre, or is it a gradual onset also. In dose-related acute effects, most often they are predictable, reversible, and concentration dependent. So commonly we see these things where we can give an assurance for this most common side effects. But in psychiatric, the attender should give the tablet and not the patient himself because they may overdose it. Gastrointestinal most often settles by itself in about 3 to 4 weeks of time. Metabolic, we should have an eye on this because sodium concentration to the brain goes on decreasing as the person ages. So these are the problems, especially hyponatremia, hyperammonemia, as well as weight gain. The first two are most important, and the movement disorders, tremor, ataxia, and nystagmus, which is very, very common with phenytoin and carbamazepine. Idiosyncratic can be Steven-Johnson syndrome, toxic epidermonecrolysis, hepatotoxicity with valproate, and hematologic, which we really fear for and hence contraindicated. Pancreatitis, mainly with valproate, and DRESS syndrome, very commonly with carbamazepine, phenytoin, very, very commonly. And nowadays, we do see with lamotrigine also, the moment they have skin rashes, if at all the dose is decreased, then probably, I have seen with 2 or 3 patients where it subsides itself and the patient acceptability is also there. Whereas in chronic, we have something like bone metabolism, as I told you with phenytoin. So we have to supplement both vitamin K and vitamin D. Folate deficiency seen with many of the drugs. So 5 milligrams per day. Like methotrexate, we have to administer with phenytoin or even with valproate very, very commonly. And cognitive is most serious one. So we have to think and we have to remember that go low, start low, go low. And cosmetic, especially for females, and we should fear about this visual field loss, especially with vigabatrin, where it has got a regular box warning for this because of its irreversible bilateral concentric constriction, and regular perimetry is required for these cases so that we do not land up in such. So the two most bothering ADRs are suicidal tendencies and ideation, as well as visual field loss. The others can be tackled to a very great extent by changing the drug also, or counseling the patient apart from the drug treatment. So we can think of some sort of solace, but not with vigabatrin, where it can cause irreversible damage, and also some of these drugs which has got a suicidal tendency. So these should be thought before we pen it out in our prescriptions. Coming to, of course, we have to think of special population nowadays because about 3 decades ago, we saw disease only after 40 or 50. Now we are seeing diseases even at 20. Okay, they may not come just with epilepsy at any age. They can come with multiple of the problems. So these 4 are the important areas where we have to think before we really write an anti-epileptic drugs. There may be on 3 or 4 more drugs also, and in any case of polypharmacy, we say that more than 5 drugs at a time is considered to be polypharmacy. So in such cases, we have to think, especially women at childbearing age, pregnancy. So this is the problem, menstruation. Okay, we have to think of enzyme inducers and enzyme inhibition, teratogenicity. All these should be taught. So the preferred drugs would be lamotrigine or levetiracetam. In case of renal and hepatic impairment, we think of renal failure, especially the dose adjustment should be made based on Cockcroft's formula, creatinine clearance. And hepatic, normally we can make it out clinically, but otherwise LFT to see SGOT and SGPT. And as I told you, phenytoin, we need not bother to a great extent about decreased albumin, but we have to bother about its enzyme induction and the therapeutic drug monitoring and the free levels of PHT. So we have to monitor closely so that there is nothing like unpredictable in organ failure. In elderly patients, we have to know the physiology. I always say to my students that we have to know 10 lines of physiology to understand pharmacology, and to understand medicine, we have to know complete physiology and pharmacology. So then our prescription will not be changed even if they go worldwide also. So this is the theme what we use, and it's usually 100%. This empirical treatment will be of a major concern, and also it will be a good thing that we practice like this so that we are dedicated and also confident. So in elderly patients, the physiology is altered after 55 itself, but nowadays we take it till 65. We will manage the story as like Indians. So here we will see to it, and most often there will be some cause for the epilepsy like stroke, tumor, or dementia, etc. So we have to investigate, and we have to prefer most often these newer drugs which are cognitive sparing as well as little drug interactions. And the older one should be used with great caution because of the cognitive behaviors as well as sedation and drug interaction because of polypharmacy. And so we have to think mainly of CYP interactions. Of course, in pediatrics, we always write the prescription based on weight based. We have to follow only that because the kidneys and the liver would have been still immature till about 6 months to 1 year. So we prefer to use the drugs which act on other mechanisms, like, for example, levetiracetam. And we have to not think at all about vigabatrin because of its visual field monitoring. Now, lastly, coming to drug-resistant epilepsy. So whenever there is a failure of two, normally in epilepsy, we start with monotherapy. Unlike the other non-communicable diseases where we have the combination treatment is the choice of the day. So this is the one what we are using in almost all non-communicable diseases. But here in epilepsy, we always start with monotherapy. But whenever there is more than two drugs, then we can try till about 10 drugs, which I will be quoting that example in my case scenario. So in such cases, it is drug resistant epilepsy where there is a failure to achieve sustained seizure freedom even after adequate amount of drug which is given as well as tolerated by the patient, whatever may be. And hence we see most of the times 30% of these patients will face this sort of drug-resistant epilepsy. It can be due to transporter hypothesis, or it can be due to target hypothesis, or it can be due to pharmacodynamic changes. So we have to think of rational and complementary mechanisms for polytherapy as well as those which responds to the neurostimulation. And if needed, we have to go for either DBS or surgery. The second choice would be vagal stimulation, ketogenic diet, then brain stimulation, and lastly, epileptogenic surgery. So, after all this, we have to come back to rational polypharmacy. So, we have to think about synergies as well as adverse interactions whenever we are choosing combination. And deliberately, we have to think of all this before we see, and we have to know about how to avoid the combinations because of those problems which were enumerated before. The best combination, complementary mechanisms combination would be VPA with lamotrigine. This is the most common one which we have seen in many of the trials. The evidence is very high, and this is the most common combination. Though we have several of these, when we consider about the rationale, the use case, and the evidence level, we have other 4 or 5 combination, but the most common one is VPA with lamotrigine. But we have to avoid this phenytoin with carbamazepine because both are inducers, both have got lot of the pearls to be thought of. 2 benzodiazepines are seen as depressants, tolerance is more. So avoid it. So multiple sedating drugs like phenobarbital, benzodiazepines, gabapentin, all these are totally sedative. Patient himself will say that instead of taking one, I'll take half, or half I'll avoid, or take on alternative days. Such is the response of the people nowadays. So we have to be careful before they come up with the suggestions or the other problems. VPA with CBZ. VPA is an inhibitor and CBZ is an inducer. Both will increase the epoxide levels and hence the toxicity. So we have to be careful with this combination also. So today is the day of precision medicine as well as genomics. Just to give a glimpse of this, genotype informs the drug's choice and pharmacogenomics is now clinical. Day in and day out, we are seeing many of these pharmacogenomics, and here are the proof for this or the evidence levels for this, where it acts at SCN1A level or at the potassium channels in neonatal seizures, or HLA gene in Chinese as well as Asian patients, and TSC1 and 2 in case of tuberous sclerosis or the multiple mechanisms which are still in developmental and epileptic encephalopathic stages, where we are trying to have number of drugs targeted at these things, especially on mTOR pathway, so that we can have, we can really think of such drugs where it can be really useful, and hence be an eye opener with this sort of targeted therapy. The practical prescribing for the physician's checklist: start with monotherapy. Drug treatment is not enough. Counsel on non-seizure effects. Warn mainly about the cognitive effects so that they will never land up with non-compliance. Never stop anything abruptly, because withdrawal can precipitate status epilepticus. Titrate slowly. Do not stop at once. Preferred is brand versus generic, like with phenytoin, carbamazepine, or VPA, where they have narrow therapeutic index. So do not substitute. Be on one only so that there is no breakthrough seizures. Driving as well as lifestyle should be counseled and should be documented so that there is no problem from the doctor's end. Now, coming to a clinical case discussion. A 22-year-old woman presents with a 3-year history of early morning generalized tonic-clonic seizures and occasional jerks on the arms, awakening predominantly around exam stress and sleep deprivation. She has been on carbamazepine 400 milligrams for 1 year with only partial control. She is on contraception but is considering pregnancy in next 2 years. So this woman is from abroad, not from India. Okay, what is the likely epilepsy syndrome? As usual, juvenile myoclonic epilepsy. Carbamazepine an appropriate choice? No. What should be she is to be switched off for? Valproate is effective, but again, it is contraindicated because of reproductive age. So lamotrigine, which has got a lower risk, is better, or even levetiracetam is preferred, but we have to counsel them for sleep benefits and also the time of sleeping record and bring it back so that they will get tuned to those things. So the transition can be, there is overlap of LTG or LEV, and titrate before tapering CBZ because we cannot stop completely. Then start with folic acid and vitamin D. Counsel, apart from drug treatment, counsel about sleep, alcohol, photostimulation, driving status, because everybody is fond of driving. Then prevent pregnancy because she's already on OCs, and then see to it that there is dose stabilization, especially with lamotrigine, and if they are on multiple drugs. A word about status epilepticus. Time in neurons, like how we say in cardiac, every 10 minutes delay worsens prognosis. So the initial drug of choice, apart from A, B, C, okay, with help and other things, the first drug of choice is either lorazepam or fosphenytoin. Midazolam can be done in children, especially buccal or intranasal, and we can repeat every 5 minutes if there is no responses seen. And second line, which is IV, mainly levetiracetam or valproate, phenytoin or phenobarbital. And beyond 40 minutes, we think of refractory, and we have midazolam, propofol, or thiopental. Intubation, mechanical ventilation. Previously, we used to use chloroform, and we used to put them on mechanical ventilation completely. So we have to look upon all these concurrently, the other things, the other differential diagnosis. And lastly, but not the least, consider even ketamine nowadays and lacosamide, and especially immunotherapy for autoimmune diseases. So a quick reference, we start with the older ones, phenytoin, carbamazepine, or valproate. When something is hindering, we go on to lamotrigine, levetiracetam, ethosuximide. Most of the time it's not used. Carbamazepine, especially oxcarbamazepine, is used. Lacosamide and vigabatrin, we have got a box warning for this. and topiramate and phenobarbital is almost outdated. I think in most of the cases they are using only in neonatal hyperbilirubinemia, never as a sedative hypnotic, and not most of the times not as an epileptic because of its both amnesias, drug automatism, enzyme inducer, then taken together causing respiratory depression, coma, as well as um, poisoning. So, and we do not have an antagonist also. So these are the problems which are met. So the first 5 are the ones which we really think of this, but we can only control. There is no prophylaxis or no cure. So we have to think each day, keep an eye on the patient so that we will give them the best we can so that they can lead a good quality of life. So the future directions, which is changing the paradigm, is, as William Gower says, what is the prospect in any given case that an arrest of the fits can be obtained by treatment? The question remains largely unanswered because no prophylaxis, no cure. It's only control because 30% of the patients are drug-resistant epilepsy. So we have anti-epileptogenesis, targeting seizure prevention by mTOR inhibitors, novel targets through AMPA antagonism or TRPC channels, or even autoimmune targets, or precision medicine or genomics, which we just touched upon. Or lastly, we have got this closed loop therapy where we have seizure prediction, responsive neurostimulation, which detects and aborts the seizures. Hence, we can go for drug delivery systems for focal delivery so that there is a complete compliance and totally minimizing the adverse effects. So what are the clinical pearls? Before this clinical pearls, I thought I'll just tell you about the 3 things what I had in my practice. The first case was a child about 7 to 9 years age, about 25 years back. He was my son's friend and they had put him on phenobarbital. This child, because the mother would not observe to such a great extent, the child swallowed about, say, about 15 to 20 tablets, I think so. And when I was coming back from the college, the mother, who was a friend of mine also, came rushing. So when she came and the boy was just sleeping, the moment I asked the history, they said about phenobarbital. I just told them, take this child within 45 minutes to a nursing home and the child will survive. So with no gadgets, no investigations, we did the clinical diagnosis and the boy recovered and he is doing very well with his married life, children, etc., etc. The second one, uh, again, the person was on phenytoin, about 18 years boy, but his father was a press reporter. So they didn't want to take to a nursing home because it would become a very broadcasting news because he was a very famous press reporter. So he came and requested. So I had to put a drip at home and stay with him for 24 hours with forced alkaline diuresis. And then after he came back, we changed it to some other drug so that he will never go back to such a situation with phenobarbital. These were about 2 decades back. But the last one I had just 1 year back where I had to not only feel with the drug treatment, but also the majority was counseling. This lady was from Kerala and she had epilepsy, uh, but it was a refractory epilepsy where they had put on all the drugs except lamotrigine and levetiracetam. And the father was a doctor. In WhatsApp group, it was not individual also. In a WhatsApp group, he just mentioned that my daughter is suffering since a week and the fits is not relieved by anything. She's undergoing tortures every day. So I just want some suggestions from somebody. So I just asked them to send the number of medications what was given, and then we just had to give a very low dose of lamotrigine with clobazam. So giving continuously with that low dose for a week suppressed all the total epileptic seizures completely. So then, after it subsided for a month or so, completely it subsided, then they came to me to meet personally. I saw so many number of drugs, but again, this was an add-on again. And then I started counseling them because that girl was married, had a child of about 3 years. So we wanted to know how they will be with in-laws, how the parents will be with the child after the child is married and have a child. Third, husband is working elsewhere. He comes once in a blue moon. So, what is the reaction? And what is her day to day life? And for 24 hours? And how is she with her own child? How she is managing? So, we tackled with all this. In addition, she had a problem of dysmenorrhea though but she had a cesarean section, and so she had dysmenorrhea continuously, which did not subside at all. So we started counseling for all this, and later on I referred her to one of my friend, saying the whole story. This might be one of the stress factor also. So I requested for a dilatation. So cervical dilatation was also done. Her dysmenorrhea subsided, and she is still on the very low dose of the drugs, but she has not got even one fit since 6 months. So these things I wanted to tell you people so that we can understand when we are dedicated and the patient is compliant, we can do wonders. So if at all, if such a thing is taken, I think all of us will be successful, whether we are just general or a super specialist. So with this few words, I'll come to the last slide. That is my favorite slide. That is the clinical pearls, which is an high yield take homes for the clinicians especially. First, treat the seizure type and syndrome, not just the epilepsy. A wrong drug can worsen seizures. Next, valproate is the most broad spectrum anti-epileptic drug, but think of active counseling, especially in reproductive females. Never abruptly discontinue AED. Please document it. Tell them 100 times to the patient. Nowadays, WhatsApp is there. You can keep on messaging in your busy schedule also, which can precipitate status epilepticus and also go on for drug-resistant epilepsy. Be careful about enzyme-inducer drugs. Most of the females are on oral contraception. So you have to think of a better choice for epilepsy or a better choice for contraception. Carbamazepine is contraindicated in absence and myoclonic seizures where it aggravates. Whenever we think of phenytoin, which is our favorite drug, please keep the 6 points in mind before adding phenytoin. 30% of epilepsy is drug resistance. So after true drugs, you have to evaluate and think of surgery nowadays, which can be curative also. And TDM only guides and does not dictate. A subtherapeutic level in a seizure-free patient does not need a dose increase at all. Please bear this in mind. Keep it on your table so that it makes you remember for every patient whenever they come and whatever they are. Thank you very much for your patient hearing. Thank you, sir.
Yeah, so I think it was a wonderful and well explained lecture. So I think Dr. Umesh Khan, I would like that. What was your initial comment on this lecture?
And it was a detailed discussion on epilepsy as a whole, including toxicity, including recent development as far as genetics are concerned, and side effect and specific drugs to be used in which conditions. I think it is a complete discussion on epilepsy.
So Dr. Umesh Khan, I think almost all the questions I find that they have been answered. But Akash, do you think that any more questions to be asked from the chat box?
No, I think that one, but I think everything has been discussed in detail already.
Yeah, but any
Dr.
Akash, you
Akash,
let Akash see
yes.
if there is something left.
My question to Dr. Padma is that for drug
So I'm
resistant
not able to
epilepsy,
see the face. I'm not able to see the face.
Uh,
Uh,
Akash
Yes,
is
go on.
visible.
should I
Yeah, you
Yeah.
should I
continue.
speak?
Continue, sir.
Uh,
Continue, sir.
uh, for epilepsy to be called as drug-resistant epilepsy, as you have said that two drugs and the seizures are not controlled, then it qualifies as drug-resistant epilepsy. So what
Minimum, sir, minimum.
beyond two drugs? So what should be the frequency? Suppose the patient develops seizures once in 2 years or 3 years, still it will be called drug-resistant epilepsy.
No, sir. No, sir. They are
Oh.
already on the drugs. They are already
Hmm.
on 2 drugs. Still,
Hmm.
the epilepsy is continuing.
Hmm.
They are
So what should the
in
frequency of?
continuation only. They'll keep on getting fits on and
Okay,
off.
okay,
They can
okay,
get
okay.
every day. They can get every hour. They can get once yearly or 6 months once, whatever it is. But they continue to get it continuously. Only then we call it as drug-resistant epilepsy.
Another thing is
Either,
that,
sir,
please,
sir.
please.
Either we have to increase the dose. If we increase the dose, we have to do therapeutic drug monitoring, or it can cause adverse drug effects. So these might be the problems. So for that reason, we prefer that to change it to newer drugs, which are quite toxicity-free drugs. But whatever said and done, we have to monitor.
Uh, I see a lot of prescriptions of clobazam.
Yes, sir,
So,
that is a wonderful drug. But we have to give it at a very lowest dose, sir, because it is a sedative. And all of us, Tam, Dick, and Harry, everybody is driving nowadays.
right.
So we have to be careful regarding that and should be given only at night.
Second,
Madam,
another question.
Akash itself asked about the role of keto diet in the drug-resistant epilepsy. So, what is the exact role of this keto diet?
Sir, nowadays eating has become one total great lifestyle modification. See, according to our older times, we have to eat less in the evenings because our physiological system is going slow. But
Exactly.
our circadian rhythm has changed. We eat so much between 10 p.m. to 12 midnight that body cannot respond at all. So they go on for anything and every problem, even at the age of 20 itself, where we never heard of these diseases in our times.
Yeah, so I think, Madam, you have answered all the questions in the chat
There
box.
is
So,
another question which I have,
yeah,
that when we
yeah.
use oxcarbazepine, I find that the drug levels which we do not correlate with the clinical outcomes.
That's why,
So,
sir, I told that's only a guide. That's only a guide for a compliance or to look for the adverse effects. It is you who will decide looking after their compliance and their adverse effects, whatever they complain or whatever you feel that it is getting worst. Can you decrease the dose? Can you maintain the dose or whatever it is?
Akash, I think we have already some time limitations. So,
Sorry,
this
sir.
was
Sorry.
really wonderful, Madam. So, Dr.
Thank you.
Umesh Khan, can you give your take-home message? Dr. Prerna Kapoor had to leave due to some reason. Yeah, Dr. Umesh Khan, so
Yeah.
can you just give your take-home message?
As I said, the more important take-home message here is that patient as well as ourselves will take care of adherence of the drugs to the epilepsy treatment. This is very significant, and the drugs should be taken with the point that it will be taken from the different group if it is really required to combine. And always take care of side effect and other parts of the treatment.
Yeah, thank you, Dr. Umesh Khan. So I think the last question just now came.
Yeah.
Throw some light on how to stop antiepileptics. Madam, just answer in
Sir,
short.
there is no question of stopping, sir.
Yeah.
There's no
Okay.
question of stopping anti-epileptics. Only thing we can decrease the dose. We can decrease the dose provided we monitor them as and when required. Maybe a week, maybe 3 weeks, maybe 1 month, whatever it is. We have to keep an eye on them so that today's theme is leading a good quality of life in between comorbidities.
So, Dr. Akash, now can you kindly summarize and give a vote of thanks from our side?
I thank Dr. Padma for delivering such an excellent talk on such a relevant subject, because this condition is a very, very common condition, and every physician should be well aware about at least the basic tenets of anti-epilepsy management. So her talk was tailored to the physicians, and I am sure that the physicians who are all attending have had a great knowledge enhancement and update about the epilepsy management. I thank Dr. Umesh Khan and Dr. Prerna Kapoor for moderating the session so well and for providing their inputs during this session. I thank Dr. N.K. Singh for conceiving regular sessions, regular updates, regular CMAs. His energy is enviable, and there is a constant updates which are going on under his stewardship. I thank Dr. Vijay Patni, who is our colleague, for being a part of our team to sort of conduct these regular CMEs. And I also thank all the doctors who have joined here to listen to the talk, because unless they join, unless they participate, we are not encouraged. So we are encouraged by their presence. I thank the USV team who have provided the digital support for conducting these regular CMEs, and their support is crucial to conduct these CMEs. I now hand over the session to USV team to finally conclude the session.
Thank you, Dr. Singh. Thank you.
Thank you, sir. So, I think that Srikant has left or whatever. So, anyway, so we have already, you have given the vote of thanks and summarized the whole episode. I think it was a real great session. People will remember,
Thank
and
you,
we
sir.
will
Thank
share
you.
the recordings also, madam. Thank you very
Thank
much.
you, sir. Thank you, sir.
Yeah,
If
so
you
good
get
night
any
to you all.
feedback, please give it, sir.
Yeah, sure. So, good
Thank
night
you,
to you
sir.
all.
Thank you.
Good
Thank you.
night.
Good night, sir. Good
Thank you.
night. Good night.
Good night. Good night.
Good night.